Making treatment decisions with prostate cancer. This is one of a series of cancer videos found on the website aboutcancer.com. There are other prostate videos that should be viewed as well. Once a man is diagnosed with prostate, he has to decide between watchful waiting or active therapy with radiation or surgery. Watchful waiting or active surveillance may be appropriate depending on the man's life expectancy and the Gleason score of his cancer. Treatment options are generally surgery or radiation. Watchful waiting may be appropriate for very low-risk cancers unless a man's life expectancy is 20 years, or for low-risk cancers in a life expectancy of at least 10 years. Very low risk would be T1C, Gleason 6, small volume on biopsy, and a low PSA density, where the PSA is divided by the volume. All these slides can be paused, of course. Low-risk cancer would be T1 through T2A, Gleason 6, and a PSA less than 10. Median life expectancy depends on age and the state of a man's health, so an 80-year-old man in excellent health may have 11 years to live, and a 70-year-old man in poor health may have only 7-year median survival. The average 60-year-old man has a 21-year life expectancy, and the average 75-year-old man an 11-year life expectancy. The odds of dying of prostate cancer, if it's untreated, is very low if the Gleason score is low, and can be quite high if the Gleason score is high. Based on a man's Gleason score, then, and his age, you can calculate the odds of dying of prostate cancer untreated. That would be read on these graphs. The anatomy of the prostate is such that you could see it would be difficult for a surgeon to widely cut outside the gland. There are calculators that will calculate the odds that the patient's cancer has already spread outside the capsule, so-called extracapsular extension. This was discussed in the earlier video. So a surgeon here would have a hard time cutting widely outside the prostate if this patient had a high risk of extracapsular spread. Radiation may have an advantage here in that the radiation field, at least the first phase, can be designed to include a generous margin outside the gland, and then the high dose rate will be highly targeted or focused on the prostate itself. The best advice is always found on the National Comprehensive Cancer Network website. They do have a patient site, nccn.com, that can be quite useful for patients. In order to use the booklet, you need to know what risk group you would be in, low, intermediate, or high. This was discussed in the earlier video. So, for instance, a low-risk patient, depending on life expectancy, may choose between radiotherapy or radical prostatectomy. With an intermediate, again, radiation with or without hormones versus surgery. And in a high-risk patient, radiation with definite hormones, again, versus surgery. More detailed information and more current information is always found on the current NCCN website. The reason surgery and radiation are both generally included is because the long-term survival or cure rates are basically the same. This is from the Cleveland Clinic with some long-term data, and the Mayo Clinic recently published similar data, 10-year survival in very high-risk patients, and you can note the excellent long-term cure rate with surgery or radiation. In order for radiation to compete with surgery, however, the dose has to be quite high, greater than 72 gray. More data shows the higher the dose, the better as far as controlling the cancer. This requires highly targeted radiation. If the cancer is outside the gland, then hormones or external beam, for instance, would be better than surgery or seeds alone. Most men decide on treatment based, however, on side effects. In general, radiation is more likely to maintain potency and have a lower risk of incontinence, but a higher risk of bowel irritability. The risk of maintaining potency is quite variable, but in general, patients with radiation are more likely to remain potent than patients who have surgery, even with nerve sparing. There are detailed tables that you can use to calculate the odds of maintaining potency after surgery. Again, all these can be paused. So a man who's young, 50, with a low PSA, with good sexual performance before surgery, has a 70% chance or better of remaining potent. There are similar type of data that can be used for external, depending on 3 factors: hormone therapy, PSA, and sexual function before external. So similarly, a man with no hormone therapy, low PSA, and good sexual function before radiation has a 92% chance of remaining potent, and the opposite would be 16%. With seeds, there are 4 things that were statistically significant: age, race, obesity, and previous sexual function. And again, these things can be paused. The best group would be a young African-American man who's thin, with a high sexual function prior to seed implants, has a 98% odds of remaining potent, and the opposite would be as low as 6%. It's worth noting that in general, Viagra-type drugs are more likely to be effective in radiation patients than in surgery, though there are other treatments for potency. The best advice is to meet with a good urologist and a good radiation and hear both sides of the treatment option. The best results are with an experienced urologist and a radiation with modern technology. There's an important learning curve with surgery, even with open prostatectomy. The more surgical procedures, often the better the outcome. And there's similar data with robotic or laparoscopic prostatectomies. The learning curve can be quite steep. The more experienced the surgeon, the better the outcome. All of this information can be found on the website aboutcancer.com, as well as other prostate cancer-related videos.